Welcome, everyone. I'd like to introduce our Dean, Dr. Thomas Cavalieri, to start today's program.
SOM Alumni Association's monthly webinar series. I'm Tom Cavalieri, the Dean of Rowan University School of Osteopathic Medicine, and we're pleased to bring another alumni webinar series to you. This evening, we explore the challenges and advances for the special needs community. We know that the special needs community has been an underserved population prior to the pandemic, and the pandemic has made the situation very difficult for so many families that rely on medical care, schools, and community programs for support. Tonight, we seek to examine this topic area from our medical experts from Rowan's Integrated Special Needs Center and our alumni. We hope to provide some important guidance to address the unique challenges of the special needs community faced by so many families during this time of the COVID-19 pandemic. The format of this webinar series will include a moderated panel followed by questions and answers from our attendees, all within approximately 1 hour. As a reminder, you may submit your questions at any time in the chat so they can be shared with the panelists during the session. It's now my pleasure to introduce our presenters and participants. I'm pleased to introduce our own Dr. Jen Lecomte. She is an associate professor here at Rowan in both internal medicine and our pediatric departments. She's double board certified in both internal medicine and peds. She served as a pediatric chief resident at Nemours and has dedicated her medical focus in providing primary care for patients with complex conditions originating in childhood across the lifespan. She currently serves as the director of our newly initiated center, the Rowan Integrated Special Needs Center, which we're very proud of, which is located on what will soon be our new campus, RowanSOM Sewell, very soon. Dr. LeCompe is a member of the Board of Directors of the Special Olympics of Delaware and is an active volunteer with the Rowan Unified Sports. Dr. Paul Abend, a 1987 graduate of our School of Osteopathic Medicine, is also double board certified in family medicine and physical medicine and rehabilitation. He serves as a clinical associate professor in our Department of Physical Medicine and Rehab at Kessler, actually, and in the Department of Medicine and Family Medicine at Rutgers Robert Wood Johnson Medical School, and medical director of inpatient and outpatient services at Robert Wood Johnson Hospital, Rahway. In 2010, Dr. Abend founded the Autism Think Tank telehealth program, now known as the Autism Healthcare Collaborative, which brings together renowned medical experts in autism to help families and their physicians manage the medical complexities associated with autism. Dr. Abend is the recipient of this year's RowanSOM Distinguished Alumni Award, and obviously we are very proud of Dr. Abend and grateful he can join us today. Dr. Wendy Aida is a clinical psychologist, and she's co-director and behavioral health lead of the Rowan Integrated Special Needs Center. She is an assistant professor in psychiatry at RowanSOM and in psychology at Rowan University. She has worked with individuals duly diagnosed with intellectual disability and mental health issues for several years. Her expertise is in trauma and alleviating mental health barriers to accessing medical care. I am also pleased to introduce student Dr. Joshua Katz, a member of the RowanSOM class of 2021 and the founder of the RowanSOM All-Star Youth Sports Clinic for Special Needs Children. He will assist us with today's program. Finally, I thank our SOM Alumni Webinar Advisory Committee members and SOM team in alumni engagement and advancement for producing today's program. Dr. LeComte, Dr. Abend, Dr. Aida, and student Dr. Katz, thank you for lending your time and expertise to address this important topic. I'll now hand the program off to our moderator, Dr. Jen LeComte. Jen?
Thanks, Dean. So we have a little under an hour to get through what we think is a really exciting topic, but has a lot of information. And Brittany, if you could just show the slides, and I'll advance through or you can advance through them fairly quickly. Dean Cavalieri already introduced our format that we'll be asking questions to our panelists. Please feel free to interject questions so that we can address your concerns as well as we address the challenges and advances for the special needs community, which are many and not exclusive to just this COVID pandemic, but certainly the pandemic has highlighted some of those challenges and hopefully opportunities for advancement. Next slide. So Dr. Cavalieri introduced the Rowan Integrated Special Needs Center already. Next slide. We are the first primary care practice dedicated to the special needs community, and we have embedded behavioral health with essential care coordination for our patients and their families. Next slide. And we really do focus on that longitudinal care for those patients. Our mission for the center is really to provide patient-centered care for all people with physical, intellectual, and developmental disabilities and their families to really provide support along the continuum of care so that they can thrive in our community. And you'll see how many of our panelists help with the families thriving in the community. New slide. So there's lots of good news about taking care of patients with different abilities, and especially for the patient population that we all serve on the panel. That the good news is that our children with special needs are surviving into adulthood. Next slide. And there are lots of common complex conditions that originate in childhood that really need to transition across to adult care and really get access to services across the continuum. So, Dr. Abend, certainly you are well familiar with autism and how it's generally considered to be a developmental disability or a neuropsychological disorder, but we're talking about complex conditions. Can you talk about how autism actually is a medically complex disorder, and what are the commonly occurring comorbidities with autism?
So I think that the statistics show that 70% of the population suffers from gastrointestinal disorders, while 36% have food allergies and 30% have seizures. The underlying medical issues often exacerbate, as we both have seen, in an aggressive and self-injurious behavior. Behavior presentations of medical symptoms are often treated as behaviors, and that's kind of a famous quote among my colleagues, that not all behaviors are behaviors and that we have to dive deeper into some sort of underlying medical problem. The metabolic differences in the autism spectrum disorder make it very challenging to treat these conditions because they often respond very differently, as you know, to the therapeutics than the neurotypical population. Pharmacology by far is the number one with the medications that really trouble a lot of us in terms of the population. At our think tank, as we mentioned earlier, we bring together well-renowned medical experts to collaborate to develop a cohesive plan of care for the medically complex child with autism. And these are experts in the fields of neurology, as I mentioned, GI, allergy, immunology, psychiatry, pain management, and neuropsychology. So with this integrative approach, it gives us a fighting chance to start dealing with a lot of these subtle issues, and some of them are big issues, this population. And the clinical care navigation program that we have also leads families when they're newly diagnosed on a path to appropriate medical, behavioral, educational, and therapeutic services. So from a lot of hardship of decades to this, we've helped a lot of people, and we plan on continuing to do that and collaborating. Obviously, you've been one of our presenters, so you can speak of that. Thanks.
No, I really do think that autism think tank can bring a lot to our patient population who are really struggling with navigating with the medical complexities of autism. But we also know, and this is for you, Dr. Aida, that medical complexities also for patients with developmental disabilities also come with complexity of mental health. Can you speak to a little bit more to, and we can go to, that next slide. Just speak to the medical complexities of the mental health conditions for those with intellectual and developmental disabilities. And I think you have to unmute yourself.
Yeah, sorry. Am I unmuted now?
You're good.
Okay. So we know that psychiatric disorders have been shown to be 3 to 4 times higher in individuals with intellectual and developmental disabilities than individuals in the general population. Between 30 to 40% of all persons with intellectual or developmental disabilities are considered to be dually diagnosed. And that means that they have a psychiatric diagnosis in addition to their intellectual disability. And about 10 to 20% of those have challenging behaviors that Dr. Abend was talking about, such as aggression, self-injury, some destructive behaviors that can lead to impair their daily life in a severe way. The illnesses that we're seeing are ones that we see in the general population as well, including major depressive disorder, bipolar disorders, anxiety disorders, impulse control disorders, personality disorders, and schizophrenia. We know that they require a higher level of care than typical psychiatric patients because of the degree of medical complexity, as well as the need for the supportive and the comprehensive community care involved. However, unfortunately, many individuals who are dually diagnosed are misdiagnosed. They received ill-informed care, or often they're not getting any care at all. Accurate diagnosis is often impacted due to atypical symptomatology that is a little bit different than the general population, and a lack of providers who have specialized training, diagnostic overshadowing, which means that we look at the behaviors and we attribute them to their intellectual disability rather than to a mental health diagnosis, and provider stigma. In typical psychiatry, we use the DSM-5 to diagnose mental health conditions. There is actually another manual that supplements that called the DMID-2, which is published by the National Association for the Dually Diagnosed. And we're able to utilize those two to be able to make better diagnostic criteria and to better make diagnoses and start to put together their treatment plan. Historically, we found that these patients tend to be over-medicated with sedation as well as antipsychotics. And, you know, most recently with COVID, we've had to really change a little bit of what we've been doing because we've been seeing an exacerbation of trauma and an exacerbation of difficulty because of the change and loss of, you know, usual activities that they do. You know, a lot of day programs have closed, a lot of schools have closed, and this change of routine has been very disruptive.
Thanks. And so just like Dr. Abend already pointed out and Dr. Aida, not all behaviors are behaviors, and focusing on a team approach, which, you know, we're all used to, really does help with addressing not only these the complex medical needs, but their behavioral needs and how we support both the patient and their families in changing times, like in a time like COVID. If we could go to the next slide. The good news is that our children are aging into adulthood, but the bad news that we already spoke about is because they have higher rates of chronic conditions and difficulty accessing services, a lot of times our patients are admitted for longer times. They have higher rates of preventable illness, and or they're admitted for really the wrong reasons, and then their admissions last longer. And unfortunately, the preventable mortality rate is 4 times higher in our patients with intellectual disabilities and complex conditions than the general population. Next slide. And that's really because of access. I mean, access to just routine preventative care. Mammograms in patients with people with disabilities are accessed much less in people with either chronic physical disabilities or intellectual disabilities. Next line. And when we compare the rates for women who have disabilities versus those who don't, we just know that they're not accessing just routine preventative health care. And mammograms are just one example of that. There are several other things, just immunizations, access to blood draws. Next line. So one of the really important focuses for Risen Center, and I think for all of us who take care of people with different abilities, is just making sure that our patients have access to medical, dental, personal care in the least restrictive environment for all patients. And that's just routine vaccinations, access to blood draws, dental care. We recognize that some patients might need sedation, but we really want to find a way that's least restrictive. And that's a pretty big challenge with this patient population. So Dr. Aida, I know we've had to make some changes in our clinical practices just for patients to access care now during the time of COVID. But can you speak to maybe both access to some of these routine preventative care and how we've maybe changed our clinical practice a little bit to increase access for patients with different abilities? And next slide, please. And
yes, as Dr. Lecomte was mentioning, at Risen Center, one of our primary focuses is to be able to help our individuals with special needs have access to routine preventative care. I know she didn't mention this, but we were able to receive a grant funding to be able to help with building this program here at the Risen Center. And initially our idea was that we were going to start off with dental procedures and trying to help decrease the anxiety and decrease the trauma, because many of our patients we found have been traumatized by having gone for, routine blood draws and having to be held down. Their family members have been traumatized having to watch this happen to them as well. So our initial plan was to kind of start off in that way, and then COVID hit. And we had to kind of rethink a little bit about what we were going to do, because we weren't going to be able to bring, our patients in to have them sit in a dental chair and work with them. And so we began working on a desensitization program to focus on mask wearing as well as inoculations, because with a COVID vaccine coming out, we want to be sure that our patient population that's particularly medically vulnerable to COVID also has the opportunity to receive vaccinations and doesn't have a barrier there because they're struggling with anxiety. So desensitization is really a progressive way of exposing somebody to a feared situation while helping them manage their anxiety and the sensory problems that may be accompanying that in order to be able to access this care. So the first thing we focused on was difficulty wearing facial masks. We're finding that a lot of our individuals have difficulty due to sensory issues, discomfort, even fear of seeing others in facial masks. And I think all of us kind of experienced that a little bit at the beginning of the pandemic when, you go into the grocery store and everybody's face is covered. And our patient population, I find, are very exquisitely attuned to the way that your face looks and being able to see you when you're talking to them and looking at facial expressions. There's some research to suggest that even going for dental procedures, that patients with special needs do better with their anxiety if they can see, if the dentist uses a shield versus a mask over their face. So what we've been doing is working with helping individuals wear a face mask, and we do that in an individualized program. We look to determine, what is the issue that's really getting in the way of wearing the face mask, and sometimes that's related to sensory issues, so we have to be a little bit, kind of playing around with different types of face masks to see what they can wear. Sometimes it's just kind of getting them used to the idea of a face mask. So many people were not able to wear face masks, so their families weren't taking them out anywhere, so they hadn't even had an opportunity to see people in face masks. So we started putting them on during our telehealth visits. I have them practice putting them on their caregivers, and then gradually working to the point that they can wear a face mask. We also know that fear of needles is common in the general population, not just for people who have special needs or autism. But we find that what we've been working on is trying to help decrease this fear of injection. We've been doing this really with our flu vaccines this year. And we, first do a very good assessment to determine what the issues are. Is it a fear of pain, a fear of blood, trauma that's been related to it, and then begin a program of education. Sometimes that includes social stories about the procedure and what's going to happen. I teach anxiety reduction techniques such as breathing, meditation, distraction. We work on trying to help the patient have some control. So I usually develop a plan for each individual of what works for them, something that they can carry with them even when they go in for a blood draw. Does it help for them to look or not look? Does it help for them to have a family member or somebody that they trust in with them or not in with them? Do they need to listen to music? Do they need to have their iPad? So that they have some sense of control, that they can do a countdown really helps. Gradual exposure, so, having them come in, maybe having them look at the medical equipment. We're very excited to be partnering and to be looking into virtual reality as we're coming forward in some of our desensitization. And then we work on sensory and pain control. So sometimes we're using a freezing spray or a gel. I have two things that I wanted to show you that are really neat for pain. The first is called a shot blocker. I'm hoping you can see this. So what this is a very inexpensive plastic piece with a bunch of just plastic prongs that stick out. And what you do is you place that on the spot that you're going to be getting the injection, and you have the injection in the middle of it. So this kind of spreads out. It's not painful, but it helps to decrease the sensation in that area. The other thing we use is this Buzzy Bee. Can you see the Buzzy Bee? So the way this works is with vibration as well as cold. These are usually frozen. And you put that on the area for about 20 seconds and it vibrates. I don't know if you can hear that. And I even did this for my own flu vaccination, and I didn't feel it at all. So these things give them a sense of control and decreases the pain.
Thank you.
You're welcome.
So, and there's lots of barriers to accessing medical care, and I think, Dr. Abend, you can really speak to that. Brittany, if you could go to the next slide. Barriers, obviously, during the pandemic have really created some different access to some of our medical facilities. But there's really all kinds of barriers to access. But Dr. Abend, in addition to these barriers, I mean, many of our parents have spoken about how it can take so long to get access to care, so not just access because our patients are having anxiety or fear, but just access to get into the doctor's office. Again, sometimes the barrier is they can't get in the door because they have a wheelchair, and some of our buildings actually aren't accessible. I'll have you know that as we build out our new Sewell campus, we really can. But can you speak to, some of or just explain what some of the other barriers are to getting access to some of these subspecialists and how maybe you overcame that with the think tank? Oh, you're on mute.
Oh, can you hear me now?
Sure can.
Sorry about that. So I just want to add one thing to Wendy's last comments, is that we found helpful, with my own son who has seizures, we were getting blood work every 3 months, and that became, for the last 10 years, quite challenging. It was self-insured, it was rough, both of us had to take time off. And it finally dawned on me, like, why am I doing this? Okay, he goes to school. They should be doing this in school. So I created a simulated doctor's office at his school with otoscopes, ophthalmoscopes, a lab chair. I had an x-ray box with a little weighted, with a fluoro jacket that they would wear, and they started working out programs with the young children all the way up, because this is reality. This is the way we have to do it, and you're right about the anxiety issues, and they've had tremendous success. I wish a lot of other schools would start doing this and start at an early age, using stethoscopes, ophthalmoscopes, otoscopes, just like we had. So I think it's great what you're doing, and these are some cool things that I'm going to take back with me, Wendy. Thank you.
You're welcome.
Those are really cool devices. In answer to your question, in the last, it's almost 2 decades now, there's clearly a shortage of physicians. We know that. There's a lack of training in medical school. This is not something my wife, as a physician myself, even knew about. And, I started a desensitization program with Robert Wood's family medicine program up north at the Douglas School, and it's been very successful. I think we need to continue doing that. I think Josh's program, when he told us about this, we jumped on board, not just the sports clinics, but the goal was really to desensitize first and second year medical students. It doesn't matter what specialty you enter into when you graduate. You are going to see this population, whether it's a young person or an old person. I see them in your office. And I think that is the starting point, which is awesome, what they're doing there at your school. The problem is many of these children are nonverbal, and they're medically complex, and they have behavioral challenges, and it requires a lot more time to evaluate them in the office. And, these are intimidating to many of the physician colleagues of mine without the experience in this population, not to mention the reimbursement rates and the pressure that we're under to see people. You're talking, I know. You have the psychosocial issues going on. You have the medical complexities. You have a child, and it's very disruptive to an office. And you're still getting a very low rate. And I've discussed with some of the hospital administrators, and they realize, too, that a lot of people use the ER as their primary doctor. Every time they walk in the emergency room, it's $895 before when you walk in the door, and it's several thousands of dollars in tests, when actually the problem is so simple as you mentioned earlier. I hear so many stories from families that it was a strep throat or an ear infection. So now we have subjected this child to an ambulance, a very frightening experience, and the family to go to an emergency room, another anxiety-provoking area, where there are million tests being done, which is taxing our system financially, for a simple problem that you and I have taken care of, and other people. So we're starting to use telemedicine more. We're starting to train more physicians to treat these problems. I've even gone so far as I've been on the chat site with veterinarians. One of my colleagues said to me in a joking manner, these guys, the dogs don't talk, animals don't talk. How are they able to do this? And I spoke to some veterinarians from Harvard and Yale, and they said to me, we are trained to listen and to observe. And I thought, that kind of struck me. And I was like, you're right. We need to start doing more of that instead of ordering tests. We need to listen to the parents. We need to be able to observe more and take a good history, because that's where the problem is. My son, knock on wood, hasn't been to a doctor or been to a hospital in 21 years. Because I've been able to ask the staff, look at him. You could figure it out. And I think we got to get back to that in terms of that. I also want to hit upon the point of financial. They realize that the financial system is breaking. They will be on the Medicare system for the next 20, 30 years. They realize that the emergency room is not acceptable right now for these families. So the money is better spent in paying us more in the office to see these patients and keep them out. And I think that is the trend. I suggested even that the large student loans that the medical students have can be used as a public service in terms of, and they loved it. So there's a lot of opportunity out there to solve some of these problems, but we all realize what they are. And the same thing happens with my colleagues who are dentists that also have kids with autism. And we're starting to bring our son and other kids to the dentist on a frequent visit to desensitize them. One of the other things that we started the Autism Collaborative is that we have a lot of physician parents with autistic kids of multiple specialties. And this is something I'm very excited about, where a couple of years ago, it was over 900 physicians in New Jersey have kids with autism. That was a statistic. And they start coming out of the woodwork. And now we have psychiatrists, hematologists, infectious disease, ER doctors, pain doctors. When you start with that groundswell, we understand it. We have been in the trenches, and it hasn't been pleasant, but we feel empathy, and we certainly understand it. It's not something that we have time to treat somebody in the office and teach them about autism, as you know, and the complexities. But the other thing is that one of the things that I love so much about the group of doctors that we have is that when they joined on 10 years ago, their sole mission, I mean, they're very busy people. They've published articles, as you know, written books. They're famous. Their whole goal was to educate the physicians on the ground. And if they can do that and they go back to their offices, then they would see and understand things that they haven't seen. And we have treated patients over in Lithuania, China, Russia. Last night we did one in Italy with a translator. We've done one in Montana, North Dakota. That's how you're going to start making a change. So that when they come in, it's like, I know this kid may have some GI issues. Maybe this kid has some seizures. Maybe this would be able, and then know where to hand off and support them and what medications are used. The biggest problem and my frustration is that these kids are on polypharmacy. My son's at 12 medications and the interactions. He's not going to tell you or she, I'm nauseous. I'm feeling lightheaded. He doesn't commit. What happens is he starts hitting himself, and it's self-injurious. So the idea is sometimes we have to taste the medicine. So, and we've experienced that, and that's kind of how I launched this whole thing when I got to Dr. Bowie up at Harvard. I was like, I don't understand. I've taken him to every doctor. And then one of the things came out that the preparation of Zantac for his stomach that somebody had recommended earlier was minty and was causing heartburn, which is found in these kids. Something so simple. And then you feel bad because you're doing it. It's not your fault. But this is something that we all discussed many times, that the side effects of these multiple medications and the interaction and the metabolism is really complex. So I'm going to stop at that point.
Thank you. And so I think, we definitely pointed out how many barriers there are. And I think one of the solutions is what we do here at RowanSOM is that we teach. And so student Dr. Katz, can you give us a little bit of perspective, because I know that you have a passion for this patient population, but how do we, why is learning about this patient population so important, and starting to work with them, and maybe describe a little bit of how you can encourage some other students to get involved in some of the community support so that they can, because I think that volunteering has been one of the main reasons that I and you have learned more about this patient population. Can you share your experience?
Thank you. So I think Dr. Abend actually kind of hit the nail on the head, kind of mentioning how through the clinic, having medical students kind of be the main volunteers to kind of learn how to even simply just communicate with this patient population, no matter what specialty they're going to be going into. I think, that's an experience that I've been able to share with my fellow students, and it's been invaluable. Through the clinic, they've loved it. Nobody, no matter what any medical student has going on, whether it's been studying for boards, classes, whatever it is, everybody was so excited to get involved. They had a great time doing it. And I think that was a great starting point to kind of, learn about this issue. For a lot of people, a lot of my fellow students, it's not based in the curriculum or anything. We don't necessarily have set rotations or anything during your third year or fourth year that's required. So a lot of people may not even get the experience to just simply interact with this patient population, which, as Dr. Abend was saying, is, it's kind of an ever-growing patient population. It's going to be prevalent no matter what they're doing. So beyond, these volunteer activities, I think a great starting point, too, from a student's perspective, I'm graduating in May, I'm on my way out, but I think maybe either providing, whether it's electives during fourth year or third year, or even, a 2-week rotation at least through the center down at Rowan. I think that would be an invaluable experience as a clinical experience for students, because talking to other students from other schools, they certainly don't have that either. And I think that could be kind of a groundbreaking sort of thing to do in addition to these community and volunteer activities.
Thanks, Josh. Actually, we agree. And we started to work with the curriculum committee to incorporate working with people with different abilities into the curriculum through the community service learning and leadership module. The good part about that is that here at RowanSOM, everyone has to go through that course, so it doesn't have to be an elective, because we don't think, and I think Dr. Abend, you pointed it out quite well, you're not going to have a choice on whether you're going to be seeing patients with different abilities, those who can't communicate with words. Certainly, some specialties really do understand how to communicate nonverbally. I think pediatrics is one, veterinarians is another. Speaking of veterinarians, Rowan University has an endowment for a pet therapy program, and how do we bring that partnership into Risen Center? They're going to be joining us for some of our desensitization programs for access. So, being part of the university, and I think students already take advantage of the pause for pets, right before exams, but really seeing how we can heighten our level of using some of these alternative therapies in order to increase access for our patients and also our own comfort level. I really think that the pet therapy will help bring some of the students who have not been exposed to patients with different abilities, who have just anxiety themselves about working with patients who have different abilities. I think exposure is key. And so having some of our pets come to help kind of bridge our students' anxiety with our patients' anxiety, and really how they can marry those units together, I think is really important. But one of the courses that Dr. Aida and I are presenting through that community service and learning and leadership class is practice accommodations, etiquette for caring for people with different abilities, because you can bring those practice accommodations to wherever you go. Now, you can't always bring the equipment. So, we're excited that at our new facility, we're going to have Hoyer lifts and wheelchair scales that really bring access of basic vital signs to our patients. Patients who are in wheelchairs don't get weighed. That's telling me I should stop chatting so much. So, and really getting a basic vital sign for our patients who have different abilities, everyone should have access to that. And we should never write in our chart, didn't weigh. For literally 20 years, I've seen that on charts. 20 years of someone not getting a basic vital sign in order to access routine preventative health care. That is not okay, and we don't think it is here at Rowan. I know that Dr. Abend doesn't, and we want every student to see that those access to basic care, is something that you can advocate for at every level, because what we're hoping, I think what Dr. Abend is saying, is that if we can build you all up from ground level, then you are going to flourish out as advocates for this patient population. I just want to get to a couple of the questions that I see here, but also encourage the audience to put out any questions that they might have. So one of the questions was, and I think that we can speak to this, Dr. Abend, you can speak to this. What happened at home to the home therapies, ABA therapy, et cetera, respite care during the COVID crisis? What have you seen with access to your home services for your son? And then maybe Dr. Aida, you can incorporate that in too.
Well, my son, he's 21, so he's off the grid there. We've got his caretakers. We have a very structured program. We do have a therapist that we've been working with, and his staff is very has been structured and has been with us for quite a while. So we have activities throughout the day that he's working on. At the same time, his vocational skills, he's actually using my office and my wife, and he's setting up and doing supplies, and it's a place to get out. You become very creative. My wife we have a yoga room for him, so he does yoga therapy, music therapy. He's on the internet, not the internet, I'm sorry, he's doing virtual training with an occupational speech therapist. You know, the day is very structured. He goes for walks when he can, and exercises is important with this population. And so he's on the treadmill for a couple hours. So he's got a full day. And I think the more engaging you are, the easier it is as a transition. After a while, it's a routine, as we know with this population. They like structure, they like routines. So anything you can think of, and I'm sure I'll think of more things as the winter is setting. I'm already in my mind is going. So those are some of the things that I'm doing. I'm sure you're doing a lot more, but you are.
Yeah, so we've had to transition. So go ahead, Dr. Aida.
I was going to say, I think disruption to routine has been really the hallmark of this COVID pandemic and really affecting our patients. You know, in terms of, you know, children who were going to school and they got sent to all remote, they did lose their speech therapy and their occupational therapy and their ABA assistance because basically mom and dad or whoever's home is doing all of those things as they're trying to learn them through a Zoom format. We know this population doesn't do well with the Zoom format. You know, although switching over to telemedicine was a wonderful alternative to having nothing, it's not the best for this population. You know, going out, having people come out to their homes really isn't happening. I do want to give a big shout out to the DSPs throughout all of this because the direct support professionals in the group homes have absolutely been there every day, all day. They are the ones on the front line in this pandemic, helping to provide the structure and the support that our patients need to kind of get them through, which is really a prolonged crisis, a prolonged trauma to them, and really helping to give them that sense of safety by keeping the continuity of care.
Thank you. So, and then we have a couple of comments from medical students. One that's near and dear to my heart is just terminology and patient first language. So Melvin Ways asks, as a medical student having multiple board review practices referring to patients as mentally retarded despite the changes in Rosa's Law, thank you for pointing out Rosa's Law. You know, how can medical students call for change? So one of the ways that Risen Center has kind of partnered with our Special Olympics partner is the Spread the Word to End the Word campaign. So we and spread respect. So they every March put out the Spread the Word to End the Word campaign, and certainly we can get more students involved in that campaign. In Delaware, they put out a T-shirt every year that has a Spread the Word to End the Word theme, and I've reached out to the New Jersey Special Olympics to also include that. Certainly, it's part of our curriculum to really talk about patient first language. I will tell you, when I trained even at Nemours, when anyone would present someone with cerebral palsy, it was MRCP, mentally retarded cerebral palsy, and they don't always go together, but for some reason, those things just got linked. One of the very first things that I do when students rotate with me or when I have a new referral, because almost always you'll see the diagnosis code of mental retardation in their diagnosis codes, and quite frankly, even some of our families, and I know you're here too, that they've become accustomed to using that terminology, and almost been desensitized. And I re-educate that, we use intellectual disabilities. I change the diagnosis codes on all my charts. And I encourage you all to do that too. So I think as we get more students through our curriculum and really empower you to be advocates, it does start with language first. So I really appreciate, Melvin, you asking that question, because I think that that's so important. If anyone else wants to comment on that.
I can't agree more. And I think we've all seen through the years the stories of people who are nonverbal who are actually extremely bright. So I think it's very unfair to assume because you don't have language, therefore they don't have intelligence or they're cognitively impaired. Being a psychiatrist, I agree with you, Jennifer, with CP. I've 1,000 times. My director of my program had CP and was mainstream in the New York school system. And he's now retired and he's very well known. So it's ridiculous to make this analogy by anybody, but that's ignorance. And I think we need to change ignorance. And the other thing is to find that, I've always been saying, every child and every adult has a unique ability to do something. And our goal, and if you look at the verticals that I always talk about, there's the residential part, there's the medical part, and there's the vocational part. And for the vocational part, the idea here is that they need to have a purposeful, meaningful life. They must be able to contribute to society, and they will. Each person has a unique ability. It's the challenge of us to figure that out.
Mm-hmm. Agreed. Josh, did you have a couple questions that you can ask the audience, from the audience?
So the next question is, do you have any suggestions for social and physical activities during this time? My daughter is very physical and needs to be active. I could maybe put in a plug for that one.
Please do.
So for sure, through the Rowan SOM Youth All-Star Clinic, unfortunately, we haven't been able to do anything in person since COVID began, which occurred on school grounds at the all-purpose room. However, we have been doing a number of Zoom sessions we call them Zoom exercise sessions, which have actually been pretty popular. And, the children who have joined us, at first, we may have been myself and Jordan Abend, who helps run the sessions as well. We may have been a little hesitant to see if they would stay focused as they were maybe in person, but it actually has been pretty astounding how well they've gone, and we've had interest from the parents emailing us back when's the next session. So we've been trying to do weekly sessions around 45 minutes where we call it interval training, where we have the Zoom session, we can see our living room, and there's a group of everybody on camera like this, and we all do different push-ups, jumping jacks, just sort of these sets of exercises to keep everybody active. So if that's something anybody's interested in on the physical activity aspect, we can definitely help out there. We can put the email in for the sports clinic, and we'll get in touch.
Yeah, we'll let Dean, you can share that information with the audience, or if you want to put it in the chat, then everyone can see. So 2 other programs that are with Rowan. So Rowan Unified Sports also have been doing Zoom activities. So unfortunately, their soccer outdoor program, they were not able to conduct even outdoors. So they did Zoom activities. So if anyone's interested in Unified Sports, you can just look in social media for Rowan Unified. You'll find some activities there. They typically also run basketball, which because of it being an indoor sport, that won't be conducted, but they'll continue to do Zoom activities just like student Dr. Katz has. And then the Get Fit program actually is still being run by Leslie Spencer at Rowan, and she is doing where you can have one-on-one personal training through Zoom as well as group Zoom training. So if you, we recommend physical activity for everyone from people who move minimally to people who are fully able to execute weightlifting and really whatever the fullest extent, as you hopefully just saw, the first person with Down syndrome just finished his first triathlon. Amazing. And again, I think that Dr. Abend already pointed out that everyone has the ability, and you know, how far they carry that ability is up to us to actually help them realize their abilities. So I think that we recommend as physicians at least 150 minutes of physical activity a week. That sounds like a lot. It comes down to 30 minutes, 5 days a week, and just walking counts. I also recommend some of YouTube's yoga, Cosmic Kids Yoga, because it's a little bit more fun. But Yoga with Adrienne, because then, especially during this time of being stressed, it blends mindfulness with movement. And I will tell you, it's been my own therapy. So, you know, certainly we know that yoga can be both therapy for some of our behaviors as well as our anxieties. I imagine, Dr. Abend, you know some other things that we can get our folks moving.
Yeah, easy enough is treadmill downstairs on low, and you can put a little video, whether it's Barney, Sesame Street, or something that's from Disney or whatever the individual likes is wonderful for 30 minutes. Some of the occupational therapists that I've worked with for sensory integration have actually used treadmills to do a lot of their therapy skills. The elliptical is something I like very much for a lot of reasons. So that's another device. Also, the little basketball hoops that you have in the house, you know, just the idea of coordination, bouncing balls, handing back and forth. You could even do, like you said, yoga. We've done some things. Just off the cuff, I just want to add two other points. You know, music therapy is very important, and not just for relaxation, but it is extremely powerful. We've done studies on this with our think tank. I don't know why the Grateful Dead is popular, except I was told because of the intonation of the music. It's not too high, not too low, but it is extremely powerful in reducing the anxiety for my son and for other kids. And then you hear other fathers driving them around. That's another thing. We're all doing our drives in the cars with the music playing on a Sunday, Saturday, same guys waving. Driving in the car, but more than that, there's a bonding that goes on. That I enjoy. That's where we connect, and I think that's important to take advantage of, because it's like riding a wave. You don't get it all the time, but when you do, it's powerful. And we're all bumping to the music. Josh has seen us in the town, so music is great in that area. And the other thing I will mention is, to be fair, we're talking about the School of Osteopathic Medicine. Myofascial release and OMT. We did a study a long time ago because of the anxiety that my son was having. And we had my brother, who's one of the professors there at your school in the osteopathic department, and a massage therapist come every single week and work on my son, who had visceral GI pain and was having somatic issues. And it was hard at first, but repetitive time. They would come on a weekly basis. They would alternate. And believe it or not, it got to the point where they came in and he pushed me out of the room. The lights were down. The music was playing. He rolled on a table. I want tickles. But it was like, no, touch therapy was calming. And he was like melting. And for a lot of these kids who have GI issues, it's not about medicine. It's about the laying on of hands and doing the osteopathic manual manipulation or treatment that they were doing. And we have successful outcomes to prove it. So massage therapists are doing it. Myofascial release is what they do. We do myofascial release, and we're trained to do that. And I just want to put a plug because it works, and it gets him ready if he's in an anxious situation to go for an injection or to be in a situation he's unfamiliar. So when we were talking about alternative therapies, I had to just throw that one in.
I appreciate that.
And I agree. And you know what? Part of what you're talking about, too, is that level of connectedness. And that's what people are missing right now, sure. That ability to touch, that ability to see their friends, that ability to be around other people. The only other thing that I would recommend with regard to exercise is making sure you get outside every day. That's something that I think really helps with mental health, to be able to, we're so stuck indoors all the time at this point, to be able to get out and to be in nature or go for a walk or a bike ride or something like that has also been really helpful.
So we are coming to the close of our time already, and believe me, we still have a lot more topics that we want to talk about, including transition from pediatric to adult care, furthering our education, letting you know about some of the electives that we're thinking about, and having students really be part of our hands-on. The research that we can get out of really showing the evidence base behind the therapies that we provide as DOs, as clinicians, as psychologists, because we know that we have to show our work in order to mainstream our efforts. And being part of RowanSOM has really heightened our ability to make sure that we can elevate the level of care for this patient population, support their families so that they can, exactly what we said, thrive in the community and be a productive member of our community. We know that they are, part of why we do this is because patients with different abilities really bring joy when you care for them, and really we want to make sure that all of our students get to experience that, because certainly we know that when some of our patients get sick, it doesn't look like that when they're in the hospital, because they look sick, and it's really hard to identify what it looks like on the outside and how much joy they bring to our lives and our communities and our families. So we look forward to our bright future at our new campus at the Sewell campus, and that's opening in March. I say March 1st, but March. We're hoping that this pandemic won't delay it at all, and we hope that you invite us back so that we can tell you a little bit more about how we can all care for this patient population and how much joy they bring us. So I think with that, if there's any parting words or any burning questions, we will end. I think it's going to go to Ashkan. I don't see her, though.
Some questions, I think, coming up here. Josh?
So there were a couple more questions if you had a minute.
Yeah, we're fine. Attendees, we're happy to continue if people have more questions.
The next question, one of the questions was actually asking about OMT, so Dr. Abend hit the nail on the head there. And then this one is good for you. I think the question was, I know it was discussed the challenges of polypharmacy on the special needs population. Do we know if there is a clinical pharmacist that residents could have access to help with this aspect of patient care, or if that even exists in the general healthcare system?
So it does. Again, Rowan University and RowanSOM are part of the Eds and Meds corridor. So one of our partners along that corridor is Inspira, and they actually have a pharmacology residency program there. We are expanding our GME, so our graduate medical education down at that location. So at Inspira Mulligan Hill, we'll be expanding our family medicine residency and internal medicine residency. We're recruiting our first classes this year. We'll expand to 12 internal medicine residents for a total of 36 over 3 years, and 6 family medicine residents with a total of 18 after 3 years. So bringing them in, part of my goal for when we develop the ambulatory practice, which will include patients with different abilities, our patients from RISN will be part of the resident ambulatory experience, is to include a pharmacy, the pharmacy resident. It won't be at the outset of the ambulatory continuity experience, but it is part of the longitudinal plan for that. And certainly there's a lot of parallels with with already the established programs within Rowan. NJISA clearly looks at that polypharmacy for our geriatrics patients, and I think that parallel is no different for our patients with different abilities. We didn't really get to talk about transition, but really I get to look at patients as they leave pediatrics and enter into the adult medicine as a clean slate, And I agree with you. A lot of times patients transition after seeing multiple specialists who didn't have one captain looking at their whole medication profile and start to peel away. That, you know, certainly some of our families get very nervous about peeling away some of the things that just seem like standard of care. And the reality is, I think we've already articulated a lot. There's more addition than reduction as behaviors change, and unfortunately, you know, that's the transition period really does give us an opportunity to kind of relook at that. So thanks for answering that question. I think you spoke about that a lot, Dr. Abend.
Yeah, I mean, that comes up often at the think tank, and it's personal to me too as well. Less is best. You just keep adding and adding, and the next thing you know, especially with these anti-epileptics, you know, procedure. I mean, and mood stabilizers. They have so many side effects that it becomes overwhelming. And I've used pharmacists from the hospital constantly. And like I said, I agree with you 100%, Jennifer. They should be part of the team. And if you could start weaning people off, that's okay. It really is. Any other questions?
Question. If you guys, it seems like a pretty good final question, and it was, how and or where can one sign up to volunteer to help the special needs community? I feel that what is being shared is important, and people in my position, patient scheduler, should be educated in order to be more sensitive to our families and our patients.
Jennifer, I'll leave that to you.
So, or Wendy, you can say how we're training some of our.
So yes, certainly we are working with RCSJ to be able to bring in all kinds of ancillary practitioners, whether it be phlebotomy or OTAs, that sort of thing. So we have the opportunity to be involved for many different levels of students within the education and within working with our patient population. You know, one thing that we are going to have in the new Sewell campus is we're going to have a sandwich coffee area, which is going to be manned by individuals with different abilities, and, you know, the opportunity to volunteer there as well. And then, you know, certainly there's Special Olympics of New Jersey. There's Rowan Unified that you can volunteer for. There's Autism Speaks that you can volunteer for their autism walk to be able to help out with some of those things. There are a lot of opportunities to be able to work with this patient population, or to be exposed and to really, you know, get the enthusiasm and, like as Dr. Lecomte said, the joy, you know, of really feeling like you're helping somebody, and somebody that, you know, may be marginalized in general. Do you have other places that they can volunteer, Jen?
I mean, really, I think once we introduce this patient population, when I started to train my staff and this was at Wilmington Hospital in Delaware, honestly, just introducing these etiquette trainings to across different specialties really opens the eyes for people, opens eyes of everyone to be advocates for this patient population. You know, what we found is in our ophthalmology department that anyone in a wheelchair wouldn't be seen because the desk was so high up. And it was simple things like that once we introduced etiquette to everyone. So again, this should be part of every curriculum. And that's another reason why being part of that Eds and Meds corridor, being, you know, we're located on the community college campus, which is no med school has ever been built on a community college. You know, having the university, you know, Bankbridge School, where Risen Center right now is embedded in a school for those with intellectual and physical disabilities. And I think that spreading that etiquette training across all of these venues really then just has people start to have an eye out for how to make the world easier to navigate for people with different abilities.
Well, hello, everybody. I'm here finally. That was absolutely wonderful. I really, really enjoyed that. Hello, for those of you who don't know me, I'm Dr. Ashkan El-Shinawi. I chair this RowanSOM Webinar Advisory Committee. I want to thank everyone for attending this evening's webinar. I'm very proud of having this really wonderful discussion close out our series for 2020. Really wonderful, guys. Note that the recording of this session will be available on our RowanSOM alumni page by next week sometime. You'll get the email notification. So feel free to forward it to anyone in your circle who couldn't make it today and who may benefit from this very important discussion. A very, very special thank you to Dr. Lecomte, Dr. Abend, Dr. Aida, and student Dr. Joshua Katz for your time and for sharing your expertise on this very important topic. Many thanks to our Alumni Webinar Advisory Committee, as well as our SOM team, Dean Natichi, Gail Foreman, Nora Casper, and Brittany Quintana for their many contributions to bring these discussions to you every month. This webinar series has been an extraordinary new community resource for our school, and we are very appreciative for the support from so many to help bring this series to you. The Webinar Advisory Committee is very busy planning programming for 2021 and developing our January program, which will provide important advice for a healthy start to the new year that address the importance of health screenings and well visits, including a little bit about smoking cessation and vaping. So please look out for that, and there'll be more information about that webinar in your emails. I also want to remind our attendees to keep up to date with happenings, news, and programs for the Rowan University School of Osteopathic Medicine. Please like our Facebook and follow our Instagram at RowanSOM Students and Alumni. Let me close by extending warmest wishes on behalf of the Rowan University School of Osteopathic Medicine and the Alumni Association to all for a happy and healthy holiday season. I, for one, am glad to say goodbye to 2020, and I look forward to new beginnings in 2021. Please stay safe and have a good night. Thank you all again.
Thank you.
Good night.